Hi, welcome to our channel. My name is Kate, and today we're going to have a conversation with Dr. Gilbert Foley. Serves as a consultant clinical psychologist at the New York Center for Child Development. Dr. Foley co authored many papers and 3 books, and the most recent book is called Linking Sensory Integration and Mental Health Nurturing Self Regulation in Infants and Young Children.
So could you explain how the early attachment impacts the mental health of the infant and young children?
Well, it's a very good question. Attachment really is foundational. It's kind of an emotional and relational platform on which development unfolds. I like to just maybe start a little bit with a definition of attachment. We know that attachment probably has roots in evolution. Dr. John Bowlby, who's sometimes called the father of attachment theory, felt that we're hardwired to attach because it has to do with survival. So that's the first function of attachment is survival. It has survival meaning, both in terms of, if we look at it in terms of evolutionary history, if you think about us as human beings, out in the savannah at an earlier stage of evolution, just think how vulnerable we were to the elements, to predators. And he suggested that our best chance of survival was to be in the company of an adult, right,
Mhm.
to protect us. So the first function of attachment is survival and safety. We are born with this incredibly elaborate inborn system of action and reaction. Babies can do a lot of things. They can socially smile, they can look at the human face, they can grasp, they can cling. And all of these powerful signals bring a caregiver into proximity. So
Mhm.
that's the first function of attachment. The baby has these inborn signaling systems. They cry, for example, probably the most powerful one. And we get alert and we come into proximity because we know the baby needs something. And then out of that comes an enduring emotional tie with a
Okay.
particular adult. So I like to think of attachment as having two sides of one coin. The one side is survival and safety, and then out of a responsive parenting comes this enduring emotional tie. Now, one of the things we know from a good bit of research is that attachment is an enormously powerful protective factor. It's not a guarantee that nothing will go wrong, but it does seem to offer us kind of an external and internal resources to help us cope and adapt. So it is a very powerful protective factor. And so we would hope that every child would have um, a secure attachment with their caregiver.
As you said, part of this is a survival mechanism, but when we now knowing more and more about attachment, could you elaborate a little bit more on why is it so crucial and how does this influence in particular the mental health aspects of the infants and young adults? Or lacking of the secure attachment, how does this might affect?
So, it really, I think, lays the foundation for relating. Our first attachment is our first falling in love. So it really sets for us a kind of prototype. Nothing is in stone, but it lays down in our memory as well as our neurology a kind of map about early relationships
Mhm.
and about how to relate. One of the things that we know about is that our early pattern of attachment seems to set somewhat of a gauge about what we are likely to expect in future relationships.
Mm.
So it does cast a shadow or a bright light, hopefully not a shadow, a bright
Mhm.
light in our capacity to relate to others. So that if we have a relationship that is secure, that is safe, that is predictable, then we're more likely to anticipate that others will treat us with availability and that we can establish an emotional tie. So it really kind of starts to set a pattern for future relationships as
Mm.
well.
Mhm.
Now, I would like to talk about how do we think a baby gets a secure attachment? There are qualities of the parenting that we look at, and they are parenting that is sensitive.
Mhm.
meaning that the caregiver is able pretty much to read the cues of the baby. Know when the baby is distressed, know when the baby's hungry, know when the baby needs a diaper change. We can get a sense of what the baby's telling us, okay? And then we respond to what we interpret as the baby's needs, right? So sensitivity, responsivity, and we do it with reliability. We
Mm.
do it with relative consistency. We
Mhm.
do it with attunement, meaning that we align ourselves not only to what the physical need of the baby is, but we align ourselves to what the emotional need of the baby is. And we do it with benevolence. We do it with a sense of well being for the baby and providing good for the baby. So, these important qualities then sensitivity, responsivity, reliability, attunement, and benevolence
Mhm.
kind of set the tone for what will likely spawn or give rise to a secure attachment. Now, of course, I think parents hear this and they think, oh my goodness, I have to be perfect. Well, we don't have to be perfect. A wonderful theorist by the name of Donald Winnicott used to say, we only need to be good enough, a
Mhm.
good
Mhm.
enough parenting, because the baby is very forgiving in a way. But there still has to be an overall pattern that would constitute a style and a tone of sensitivity, responsivity, reliability, attunement, and benevolence.
Thank you. And I think this is very important. A lot of clearly coming to me that what are specific aspects and how it could look like. And and you mentioned the needs of a child, the infant and the young child. What would be the needs? Because I think some of the needs are sort of typical, like physical needs, but maybe there are some other needs that parents should be attuned to, should read the clues.
We want to always look for cues of distress,
Mm.
that the baby cannot regulate themselves. So let's say they're in a state of hyperarousal and they're fussy, and it may signal that the baby can't get themselves back into a regulated or calm state, and that the child needs us to be a co-regulator. We
Mm.
need to help the baby to get back into that state of contentment. So I think reading the cues about the mood of the baby, the emotional state of the baby is as important as reading cues, obviously, about hunger and, other kinds of physical discomfort. But we really want to be reading the cues about emotional discomfort. And of course, we want anything that has to do with safety. If the
Mm.
baby is any way feels threatened or appraises the environment as dangerous, then of course the baby particularly needs our help to cope with that situation.
And I would assume that in the real world, let's say, the baby might want to be held, let's say, or somewhere being closer to to the caregiver, to the mother or the father. So being in a physical proximity, something like that, right?
Absolutely, Kate. I'm glad you
Mhm.
underlined it
Okay.
because really, at the beginning, certainly, these inborn patterns of action and reaction that babies have, their real function is to signal a caregiver into proximity. So,
Mhm.
proximity is a very, very important piece of our responsivity, right?
Mhm.
That the
Mhm.
baby needs us to come close and needs to provide that sense of safety
Mhm.
and security.
Talking about proximity, and I understand that it's not always possible due to, some reasons. I wanted to ask you specifically about premature babies when the baby is getting separated with caregivers very early due to physical issues or medical issues. If there is any data about that, how does this affect the mental health and attachment pattern for these babies?
Another excellent question. Be having some distress in infancy, possibly having to be in the neonatal of intensive care unit, the NICU. Of
Mm-hmm.
course, this is a high stress situation for babies. And one of the things that I have become increasingly aware of in my colleagues is that, the NICU experience, of course, it's to save the life of the baby. But
Mm-hmm.
from the viewpoint of the baby, it might actually be quite traumatizing.
Yeah.
Because I've often imagined as a baby, it may not feel like you're trying to save me. It may feel more like you're trying to kill me. So I think recognizing that it can be a very high stress situation for the baby And of course, they're often getting multiple handling out of
Mm-hmm.
necessity, which is not ideal. So, of course, it can undermine the attachment pattern. And this is why, as much as it is possible, NICUs have become increasingly more parent friendly. And
Mm-hmm.
we want parents there as much as they can be so that
Mm-hmm.
we start the attachment process starting
Mm-hmm.
right in that stressful situation. So parental presence is a very key factor. But I do think we also have to, keep a little bit of a skillful eye watching these babies in terms of their reactivity to stress and any signs of trauma that they
Mm-hmm.
might have from the NICU experience. I treated a little girl from
Mm-hmm.
about 18 months to 6, and she was a twin, and her older twin had not been in the NICU, but she was for an extended period, and she had an eating disorder, and it seemed as if that the eating disorder was likely secondary to the kinds of more invasive procedures that they had to obviously get nutrition into her. We want to keep a watchful eye that these babies might have some indices of some kind of a trauma.
I'm becoming super curious. When we're talking about mental health, I usually imagine someone more adult, let's say, okay, maybe a child 5 years old, etc. And you're talking about really, really small children and babies. So, what would be the cues that the parent might keep in mind of looking at if my child actually has this trace of post NICU trauma or something that I would be rather aware of as a parent so I could seek for help? Like, what might be the signals?
Well, I mean, I would certainly look at the general relatedness of the baby. Is the
Mhm.
baby responsive to our care? Does the baby send us those signals to want to come close? Can the baby use us when we do, in fact, come close? Can they calm? Can they nestle into our bodies? And so I really look at the quality of the relationship both
Mhm.
ways. Uh,
Mhm.
because it is a bi-directional process, right? We as
Mhm.
adults obviously have to do most of the work, but babies also have their part. So are they participating in a relationship? Do they seek human connectedness? Do they respond to our ministrations? Do they calm down? Do they become comforted? And
Mhm.
then we would want to look at any, specific symptoms that might arise. Like in this particular girl's case, it was avoidance of eating, for example,
Mhm.
sleep disturbance, any changes, of course, in eating, sleeping, and digestive functions. These are always the first signs sometimes that something is up because the body for babies is the mirror of their inner life. And
Mhm.
so it often comes up in the body. Unusual or changes in patterns of eating, sleeping, digestive functions are all kinds of markers that we would want to look at.
Mhm. And how would any typical intervention would look like from the professional side point? Like, what would you do as the professional to help these parents and a child of very young age? What would it be?
Well, first, of course, it's understanding the problem and getting a
Mm-hmm.
history from the parents and observing the child and the child together with the parents. So again, our interventions now are always at least at least a parent and a child or both parents and a child. We no longer, see these children alone. We see them in the context of a
Mm-hmm.
relationship.
Mm-hmm.
And so our role as infant mental health specialists, if I may make an analogy, it's a little bit like marriage counseling for parents and babies. In other words, we're trying to help that parent and baby get into sync with one another, help the parent to baby better read the cues. What
Mm-hmm.
might they be missing? And also, again, I just want to emphasize this is a two-way street. So, in the past, there was a lot of always blaming the parent. Well, it's
Mm-hmm.
not always the parent. Sometimes children come into the world with differences in their sensory systems, which we're going to talk
Yeah.
about, differences in their underlying developmental capacities that may make them very difficult to read, even
Mm-hmm.
for a good enough parent. So, for example, early in my career, I worked a lot with very young children with cerebral palsy or who had risks for cerebral palsy. Well, these babies were challenged for even perfectly wonderful parents because
Mhm.
often they didn't like to be picked up. Often, when they were picked up, instead of molding and melting, they stiffened.
Mhm.
And so it became very challenging for parents to read their cues. So again, it isn't always that the parent's not doing their part. Sometimes the baby is having trouble because of their neurology, et cetera, of doing their part. And
Mhm.
then the parent has to work harder to read the cues. And this is where we come in as
Mhm.
infant mental health. We watch and we coach and we point out. So we help that parent and baby to get into a kind of synchrony.
You were saying about that this is a two-way street, and I totally agree because feeling related and feeling attached to your baby, that also a journey that the parent goes through. It's not always like momentary happens with giving birth.
So we think that actually attachment starts in pregnancy. As parents, you begin to prepare for the child. You begin to have fantasies about who will this child be? What will they look like? Who will they become? And that's really all part of the falling in love. We're falling in
Mhm.
love with who we imagine the baby to be, and then we fall in love with the fetus. So ideally, we come to the birth in what I like to think of a state of attachment readiness,
Mhm.
and then it is the baby itself, the miracle of the baby that transforms that attachment readiness into a real desire to nurture, to minister to the baby. But I
Mhm.
also want to point out, parenthood's not a magical thing. And we have a lot of societal myths. That you're supposed to instantly fall in love with this baby. You're not supposed to have any doubts. And of
Mhm.
course, that's not real. Everyone has some ambivalences. Sometimes the baby you got isn't quite the baby you imagined you
Mhm.
were going to have.
Mhm.
And sometimes it takes a little adjustment to accommodate to the real baby you have as opposed to the fantasized baby. Now,
Mhm.
sometimes we all know some children come into the world with definite challenges, such as cerebral palsy, such as autism, where that baby isn't so close to the baby you imagined. And then, of course, that process of falling in love takes a little longer and a longer adjustment. But ambivalence is normal, and some time to adjust is normal.
And I think it's important to speak out about this clearly so we debunk some very still common myth that it's all roses and it's all, ideal because it's not. And many women face, and men, I think they
And that's
face
good.
completely different experiences that they were thinking of.
That's right. We do look to our own attachment patterns.
Mm.
This tends to have a transgenerational quality to it. So the quality of my attachment is going to impact the attachment that I'm likely to have with my baby. So for example,
Mhm.
there is research that has shown that there's about a 70% concordance between the attachment classification of the mother and the baby at 1 year. So, if our own history is one where we've had attachment disruptions, or
Yeah.
we have a pattern of attachment other than a secure attachment, let's say an anxious attachment, or an ambivalent attachment, or even a disorganized attachment, which is the most severe, then that's going to impact our capacity to attach to our own baby. So, our own history plays into this. And of
Yeah.
course, if we've had a trauma history, that's also going to have possibly some impact on our availability to attach. Because it's really our emotional availability. You see, this is as important as our physical availability.
And also, I think that as we starting to have children a little bit later in the life than maybe 50 years ago, let's say 100 years ago for sure. So we also, by that time that we have children, we usually already have some careers and some social life, etc. And being so attuned and ready for somebody who is so demanding usually at the very 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 early age is a complete shift how you lived your life before, let's say, and what is expected of you by your child, which is sort of normal. Of course it's normal because this is how we the whole evolution work, but that's completely different to what you get used to an adult.
Absolutely. With changing demographics and changing ages of childbirth, parents are able and likely feel a loss of their former life.
Mm-hmm.
And the kinds of adjustments they have to make in their life. And I think that's a very, very normal reaction. In a certain sense, we have to be as gentle with ourselves as we are with a baby in this unfolding process of falling in love.
I love this metaphor of falling in love. It's very true. It feels very true. So, what I was thinking that maybe we could move a little bit forward into the idea of brain development, self-regulation, and sensory integration. And I wanted you to explain a little bit more because we hear a lot that the attachment and the quality of the attachment actually affects the brain development of the child and sort of the way it's wired. And could you explain a little bit more how exactly it works?
Well, of course, we know the brain is not fully developed at birth. It's a work in progress. In a way, that's the beauty and the risk, right? The beauty is that we have this extended period of dependency and this extended period of brain maturation.
Mm-hmm.
And that means that we have ample time to, in a sense, get it right, and that the brain is plastic, and if we make mistakes, we can make changes. The downside, of course, is that it's a very long period of vulnerability. And I always like to think that's sort of, in a sense, price we pay as
Mhm.
humans for having a big brain. The
Mhm.
price we pay is this long period of vulnerability.
Mhm.
So it means then that parents do need to be available. They do need to be in relationship with their baby. And we know that the brain, just as the body depends on nutrition to
Mhm.
grow, the brain depends on stimulation. We talk about stimulus nurturance. And so here's where the parent comes in. The parent becomes an important conduit, a kind of auxiliary to the baby, and brings the stimulation of the world to the baby.
Mm.
But in a sense, they do it in a way, I like to think of it this the way the mother robin pre-digests the food for the baby. We
Mhm.
as the parents pre-digest the stimulus of the world, and we modify it so that it is accessible to the baby, so
Mhm.
that we don't overstimulate the baby, but we bring touches, of course, ourselves. And one of the important things is back and forth. We
Mhm.
know back and forth what some sometimes called serve and return. The baby sends a signal, we respond. This pattern seems to be a very, very important feature in early brain development. So, bringing the stimulus of the world to the baby in a form that the baby can process, and also being emotionally available and
Mm.
engaging in this important process of serve and return that can be touches, it can be visual, it can be vocal, and eventually, of course, it becomes conversational give and take.
And if we talk about the influence of this serve and return and the attachment and communication with the child, and you were saying that the child needs some sort of a co-regulator, us as a co-regulator of their state. So could you explain a little bit more why the child cannot regulate themselves and until maybe what age and why they need adults to help them?
Well, we know that very early, of course, right in the newborn state, the baby's brain simply isn't mature enough for the baby. I mean, they can't even regulate their body temperature, right? So we
Mhm.
have to be sure to keep them warm, for example. So I think it speaks to the level at which they're able to engage in their own self regulatory mechanism. So
Yeah.
very early in that 2 months, 3 months, the parent is almost an external regulator for the baby. Then, as the baby begins to be more of a participant, then we serve as a co regulator, meaning that we help the baby to calm down or we help the baby to get into an alert state, for example. And we might do that by touching, rocking, holding, all the things, singing, walking, all those wonderful sensory things that we do. But eventually, of course, we start to turn some of that over to the baby in increments so that the baby starts to practice how to get themselves quietened down, or the baby learns how to wait for the bottle. This
Mhm.
is all part of self regulation. And so we start not always doing all of it for the baby, right? And we start turning over some of the regulatory function to the baby
Mhm.
as they begin to learn to practice to regulate themselves, to move towards self regulation. One of the things that I think is a big misnomer and a big problem, I think sometimes we want to go too quickly to turning it over to the baby. Even in preschools, we know that actual real self regulation from the top down doesn't really begin even till around 5 or 6. So
Mhm.
up until that time, the baby still needs us as a co-regulator, to give structure, to give words, let's say if they're in an emotional state and they're ready to
Mhm.
process
Mhm.
language, to use words to cool them down. And not depending on the baby or even the young child to do it all themselves, to be able to put on the brakes completely from their own head. But I think we sometimes expect children to be able to do that too soon. And that's why I like to underline our role as a co-regulator with the baby.
Mhm. Yeah, I think this is very important of what you're saying because if we're talking even about younger children, let's say up to 1 year old, like many parents expect children to fall asleep by themselves, let's say at 3 months, at 4 months, and I don't think that this is a realistic expectation of a young child.
Yes, and they will continue often to need help because that's again, it's a regulatory process. They have to get their whole consciousness into another state to get themselves into the sleep state. And then, of course, they also have to deal with the anxiety that's associated with sleep because remember, sleep is a loss. It's a
Mm-hmm.
loss of daily life and the presence of the parent as we know it. Yeah, children need help with some of these. Another big one is transitions.
Uh-huh.
Children need help with transitions much longer than we think. That's how I like to think about regulation. Regulation is how we change gears
Mm-hmm.
from one state of mind to another, or one state of emotion to another, or one level of consciousness to another. And children need help with that.
Mm-hmm.
Again, incrementally less and less, but they still
Mm-hmm.
need us to be there and be helpful.
So if we talk about a child who is maybe, let's say, 1, 2 years old, but I know this is a huge difference, but let's talk about this age group. Before 3, let's say, what would be the healthy ways for parents to promote self-regulation at the same time, not to abandon, I would call it abandon a child too soon? So what would be the approach?
Well, I think certainly, as I had said early, we are more of an external regulator, and the baby needs us to be pretty close a lot of the time, right?
Mm-hmm.
To help with feeding, to help with keeping the baby content, etc. And then as the baby starts, I think you pointed up about abandonment or about leaving the nest. As the
Yeah.
baby starts to leave the nest and they creep out, then here again, we read the signals. And when the baby is ready, we let them go, right? But
Mm-hmm.
we don't abandon them. You see, we
Uh-huh.
stay there as a secure base. Because when the baby's out there exploring the world, the junior toddler's out there exploring the world, and they start to get anxious that where's mom, where's
Mhm.
dad, that
Uh-huh.
we're there and they come back to us and that they have someone to come back to be
Mhm.
reassured, to be emotionally refueled, to be regulated. And then the baby says, I'm ready to go back down and explore the world. And we read that signal and we let them back down. So
Mhm.
I think there's a big shift from, total external regulation to being this secure base who's there like an anchor. But we let the baby start to take the lead about going out into the world and then returning when they need to be comforted. That kind of.
So that's a fine balance between encouraging and still being there when it's needed.
Absolutely.
Mhm.
Exactly, I couldn't have said it better.
So, we also wanted to touch, and we talked with you that we would like to touch on the topic of sensory integration and regulation. I think that's very important one. But before we go into the make a deep dive into it, could you explain a little bit more for parents what is this and why is it important to talk about it?
So I'm gonna begin with an adult example
Okay.
because I think we can identify with that. So we are constantly first of all, we're constantly processing sensory information. We live in a sensory bath. I mean, if you think about it, right this minute, there's lights, there's sounds,
Yeah.
we're getting sensations through the skin, we're getting pressure from sitting,
Mhm.
we're bombarded. So part of regulation is really managing that sensory bath. Because if we couldn't filter out all of this data, my goodness, we probably couldn't function. So that's one part of regulation.
Mhm.
The other part of regulation is how we modulate and grade our reactivity to sensory information and emotions. So,
Mm.
for example, if you're at a fair, right? We're in a state of usually high arousal, expressive, probably a lot of loud noise, and we're accommodating that. But then, if all of a sudden our spouse or our partner comes over and asks us a question, we have to shut all that down. We have to refocus ourselves, and we have to attend ourselves to our partner. Now, we've
Mhm.
had to completely shift gears in our arousal, in our reactivity. So that is that's really a lot of what regulation is. It's our ability to grade and modulate reactivities to our
Mhm.
general level of arousal, to the information coming in both from outside and inside. Because remember, we're always getting information from the inside of our body too,
Mhm.
and then grading and reacting to the sensory world around us. So
Mhm.
again, we're gonna be at one level of arousal at a soccer game, than we are going to be at a religious ceremony, and we have to be able to have that ability to modulate all of this, ideally, hopefully, mostly ourselves. And that's what we mean by self-regulation. But all of us continue to need to be co-regulators, Kate. I don't know.
Mhm.
Think about this situation. You're out, you're having a good time, you're at a party, and you may have had a little too much to drink, and someone starts to pick a fight, and things get hot, and your partner or your buddy comes over and says, "Hey, I think it's getting a little too hot in the kitchen. Let's take a break." That's co-regulation. So we adults continue to need co-regulation, by the way.
Completely. I think, we as humans, we need other humans to survive.
Absolutely.
Specifically for this reason as well.
So
Mhm.
regulation then is very, very important, because if we can't get ourselves into the regulated state, I think you can see what's happened. Our behavior will be inappropriate to the context. And
Mhm.
to also think about learning. Learning requires us to be in a fairly regulated state. I
Mhm.
mean, if we are too distracted, or if we have intrusive thoughts or feelings, or we're in a state of arousal that's either too agitated or too low, we're not going to be in a state that's ready to learn. So,
Mhm.
regulation is pretty foundational. We talked about attachment as foundational, and it is, but regulation is part of that platform on which we do it.
Mhm. Mhm. This ability of integrating sensory stimuli, let's say, and regulate as the response to them, how is it different in infants and young children? And how does this develop? And what are the maybe critical milestones, let's say, again, we as parents could look for?
So, of course, it is ultimately regulated neurological. I mean, it is a neurological function, although it's also learned. So it's both. There's a neurological piece to it, but we also practice regulation.
Mhm.
And so I wanna underline that. Every time you say to a shush, you're practicing regulation.
Mhm.
Every time you say slow down, we're practicing regulation.
Mhm.
So again, it is a neurological function, but it does have a big learning component to it. So
Mhm.
very early on, we know children start to regulate, for example, when they can start to wait for the bottle, right, or the
Mhm.
breast, right. They know it's coming, and you start to say, "It's going to be here. It's coming," and the baby can keep themselves are quieted. When a baby sucks their thumb or a pacifier, they're regulating themselves, they're soothing themselves. This is the beginning of self sufficiency. This is the beginning of self regulation. So it starts out with these ability early, the ability of the baby to kind of calm, to start to wait, right? And then, of course, it gets a little more complex as children get older. Once the child starts to get into the world more, And, they're playing with pots and pans, but we have to end it, right? They have to be put away.
Mhm.
Well, that's a regulatory function. Can the child do that? Can the child,
Mhm.
with some help, get themselves calm? Can they put them away? Can the
Mhm.
child start to slow down or get quiet on a cue?
Mhm.
This is another marker of regulation. Can this child then start to regulate themselves? Sometimes by actually private speech. You'll sometimes see these kids talk to
Mhm.
themselves and they kind of
Mhm.
calm themselves down.
Mhm.
Do they increasingly start to calm to language? So if they're a little bit hyper aroused emotionally, can we cool them down by talking, for example?
Mhm.
So it starts sensory and then it becomes increasingly more abstract, and we start doing it with symbols to calm ourselves down, and we start to do it in our own head. Now, one of the examples I often give is this may not be the case in Cyprus because it's probably not as congested, but I live part of the time in New York City. And there are times when the traffic is horrible and you get yourself in a state close to road rage, right? And you get agitated. But then you think about what you might like to do, or you say some not nice things in your own head, but you
Mhm.
don't do them. And
Mhm.
here again, it's this mental process or the manipulation of symbols in our head, whether it's self talk or images, that's acting as a shock absorber
Mhm.
between a felt need and a behavior. Now,
Mhm.
ultimately, that's what we want children to be able to do, increasingly have these mechanisms, these symbols in their own head so that they can start to calm themselves down.
Mm. This is super curious because I still know a lot of people and could hear sometimes that, let's say, an infant, a very small child, starts to suck the thumb, and some people would say, don't do it, or try to make the child to avoid doing this, which sort of, from what you're saying, actually not helping the child to learn the self-regulation. But maybe this is not the ideal tool, but maybe this is the only tool they have right now at their age.
Absolutely. I mean, obviously, there are problems if a child can't give up the thumb sucking, can't give up that kind of regulation. But early on, yeah, it's really the baby doing it for themselves, and it's really the antecedent of self sufficiency. So,
Yeah, or the other example which came up to my mind, like when the children, the age of 2 or 3, they throw things, or they yell at you, and then probably with some, at 5 years old or older, they start to talk what they would do with the other person, like really sometimes very awful things. And we also, more often than not, we don't say this. This is rude. This is awful. You cannot, use these words. But from what you're saying, it looks like this is their self-regulation journey.
right. And as you say, sometimes the things we sometimes say in our own head as self talk first have to be externalized
Yeah.
in communicating and sometimes even in acting. Now, we want to go from action to, using language, which is very important. But it's a process. Now, of course, it's also part of regulation is knowing when to say it. When do we say these things if we can't do them in our own head?
Mhm.
There's a wonderful saying, and actually both Sigmund Freud and Anna Freud quoted. I think the saying actually came from Immanuel Kant, the philosopher. But he said, the first man who threw an angry word instead of a spear was the true founder of civilization. And
Mhm.
that's really where that's sort of where we're going with regulation, right? So instead of as you say, instead of the pushing, the child starts to say it. And then they start to say it in their head instead of saying it out loud. And this progression toward you being able to use more mentalized ways of regulating ourselves is the direction
Mhm.
we want to go.
Mhm. And I'm just thinking that this understanding of this concept is super helpful in the daily life because you then see this as a part of the development of the child, and you see, okay, that the next target is that, okay, I help to learn the child when is the appropriate time to say this, or maybe then, I teach the child to say it in the head and not act upon it. But
Okay.
it's not that I'm saying, okay, you're a bad person, because you said that it's not appropriate, and you basically just shutting this down without providing the alternative or the perspective that this is a process and you will learn to do it differently. It's not ideal right now, let's face it, but that's okay as well.
I like your word perspective
Mm-hmm.
because I think that's what's important, and we can't expect the child to do it all themselves too soon. And at each developmental stage, there's appropriate behaviors, and so don't expect at 2 what won't come until 5.
Yeah.
Developmentally appropriate is a key concept here, in this perspective.
Yeah, and I completely understand parents as well because, when you're in the heat of the moment and something was thrown to you,
Sure.
and it's difficult to remember about the
Yeah.
developmental stage.
So I think what you're telling us, Kate, and this is important, is that children will also challenge our regulation. And it's normal they will challenge our regulation. And sometimes we won't be as successful at regulating ourselves. Being a co regulator for the child also means we have to regulate ourselves. And there'll be
Mhm.
times when we're not going to be perfect at it, right? Or our
Yeah.
own regulation will not be working as well as it should.
We also need a co-regulator for ourselves.
As you said, we need people, and that's what friends and mates and
Mhm.
partners are often. That's one of their roles often, is to help us in our regulation, be co-regulators for us.
Gil, what I wanted just to double check with you right now,
Sure.
is it okay if we will now go into the topic of the dysfunction in this sensory
Yeah.
processing, in the sensory processing disorder, basically, and then I will share the screen. And maybe then, if we will have some time, we could talk about some don'ts or mistakes that parents could make in this sensory integration development process.
Sure. Absolutely.
Would that work?
Absolutely. That's beautiful.
Okay, so let me just share the screen. Can you see the slide now?
Yes, I can.
So, would you please explain a little bit more on what could go wrong with the sensory integration and regulation, and what again parents should look for as potential red flags?
I just want to preface this by saying did a book recently, you may see a slide, with Dr. Susan Stalling Saylor. She is the first author, and she is an occupational therapist. Now, most of the research and most of the treatment for sensory processing disorders actually come from the field of occupational therapy. I'm
Mhm.
a psychologist, not an OT. I have deep respect for OTs and I've worked with them. And I'm looking at it through the lens of a psychologist, so I'm not an OT. At some point, you may want to talk with an OT and have it from their perspective. But sensory integration is, I guess, the simplest way to say it. It is the ability to organize and process sensations from the environment and the body for use. I think we forget the use. We use sensory information to get us alerted. We use sensory information to get us calm. We use sensory information to get us from one state to another. So we use sensory information, and this is largely done neurologically. But again, there's a big learned piece to it. What we've been able to do through the work of again, most of this has been spearheaded by OTs, people like Jean Ayers, who was considered the mother of sensory integration, people like Lucy Miller, my own co-author, Susan Stalling-Saylor. They've done a lot of the research that have identified what we call sensory processing disorders. These are situations, and they're two very broad ones that we talk about. We talk about sensory overresponsivity disorder.
Mhm.
And this is where children and adults, by the way, adults have them because they do not tend to go away spontaneously,
Mhm.
where we overreact in one way or another to certain sensory stuff. Now, it can be one sensory system, it can be multiple sensory systems. And it's also important to remember that the sensory systems, they work in concert and that this is cumulative. So it's not just one sensory system. We might be more sensitive to auditory input, for example. You hear today a lot about misophonia. which is a term that is used for hypersensitivity to the auditory system, but there are other to touch, to vision, etc. So these are children and adults who are hypersensitive to
Mm-hmm.
various types of sensory input in the environment. It's real. I mean, it is real. It's a biological thing. These sensations it feel aversive. They feel toxic to these individuals. Now, where the psychology comes in is that the sensory overreactivity, they do quickly become psychologized
Mm.
because we react to them. Then people react to the way we react to the sensory stimuli. And before you know it, now you've got what is a neurologically regulated function now also starts to have relational and other meaning to it. So that's
Mm-hmm.
why I say these quickly become or psychologized. So sensory overreactivity is one disorder. Another disorder is sensory underreactivity. And
Mm-hmm.
I really want to just, if I can take a minute, Kate, to say I worry about the kids who are underreactors because these are the
Mm-hmm.
kids that get missed. They are
Ooh.
apt to fall through the crack. The overreactors are a little bit like the squeaky wheel. You're going to know these kids.
Yeah,
These are the
yeah,
kids who can't calm down. You're at a birthday party, everyone's having a good time, but now it's time to come back together and sing happy birthday. But Johnny can't calm down. He's still whirring around and still a buzz. That may
Yeah.
be the child who is sensory overreactive. And you're going to notice these kids, right? The
Yeah.
kids we sometimes miss are the underreactors. These are kids who can't quite get their system going. They're a little
Ooh.
sluggish. These are the kinds of kids you can't get awake in the morning. These are the kinds of kids who everyone else is having a good time and they're kind of like still look a little droopy and a little, they can't just get their engine going. And the underreact often get missed because they don't create a problem. And these are kids who often need a little more sensory input
Mm-hmm.
to get their engine turned on. I sometimes make a simple analogy, Kate. I don't know if you've ever driven a car where the idle is either if the idle's set too high and you stop at the light and the car's still racing, right? You have your brake on and the car wants to lunge forward. Those are
mm-hmm,
the underreactives, right?
mm-hmm,
Then you may have your car where the idle is set too low and you stop at the light and it wants to conk off on you. Those
yeah,
are the underreactors, if I can give
Mm-hmm.
you a simple analogy.
Mm-hmm.
Then
Mm-hmm.
there's a third group called sensory seekers. And these are kids who just some way can't seem to get enough.
Mm-hmm.
These are the kids, they've been on the merry-go-round 3 times and they could go on 10 times.
Mm-hmm.
They're always looking for sensory input. They tend to be risk takers. They're feisty often, and they're sometimes apt to get themselves in trouble because they
Mm-hmm.
tend not to heed to their own safety. So,
Mm-hmm.
3 broad categories then: the sensory over responders, the sensory under-responders, and the sensory seekers. Now, there's some similarities between the over-responders and the seekers, but the difference is the over-responders are apt to react in the moment, where the seekers will be always looking for the high arousal and wanting to do the daring thing. So these are kind of 3 broad types
Mm-hmm.
of sensory over or of sensory processing disorders.
And maybe you could a little bit cover the red flags that we are sharing right now.
Yes.
So, what are the most we are not going to read them through, but just what are the most critical to look
Yes.
for?
So these are some red flags. These really were put together by my colleague, Dr. Susan Stalling-Saylor, who's an OT. Again, I think some of the important ones right from the beginning are these babies who seem to have chronic unresolved colic and general irritability. We know many babies have colic, but it tends to resolve. Those
Mm-hmm.
babies where it doesn't resolve, these may be the babies that we sometimes call fussy baby syndrome. These are babies that are very hard to calm down, very hard to get to sleep, very hard to they get them asleep and they're awake on a dime. And these are a challenge for even good enough parents. These
Mm-hmm.
babies, if you have a baby who you just can't seem to get them into a regulated state and keep them in a regulated state, this may be an issue in the baby's arousal system and their sensory systems. Again, sleep issues, always to keep in mind the baby you can't get to sleep, the baby who you have a hard time getting up in the morning, you can't get their engine running. Of course, gaze aversion and poor eye contact, that can come from any number of reasons. And of
Again.
course, we think of children on the autistic spectrum. Now, one of the things we do know is that about 82% of children on the autistic spectrum do have at least one sensory atypicality. But
Uh-huh.
important to remember, as a colleague of mine used to say, every child on the spectrum has sensory problems, but not every child with sensory problems has autism. But so
Oh.
gaze aversion doesn't want to be held,
Mhm.
seems most content when left alone. These are kids often who find these are sometimes the sensory overreactors. They find certain sensations to be toxic to them. They doesn't feel
Mm.
good. So not only do they sometimes overreact, they sometimes will learn to avoid sensory stimulation because it doesn't feel good. Unexplained fearfulness. And then, of course, if these problems continue from 3 to 5, then again, the sleep problems, children maybe who are picky eaters might
Mhm.
also have some sensory issues in the mouth, foods that are too crunchy, difficulties with different thermal sensations. Kids who have problems with motor planning, with common objects, seem to know how to use their body in space. That can sometimes be secondary to sensory because remember, moving, we're always getting sensory feedback from our movement. It helps to guide our movement. So, very
Mhm.
often, children with sensory processing disorders may have some secondary movement. Again, excessive fear or lack of caution are also signs. And then, of
Mhm.
course, they're the ones, you hear of a lot children who don't like to wear certain textured clothes, children who
Yeah.
don't like their hair combed, children who can't tolerate having their teeth brushed. These may be children who may have some type of a sensory or tactile overreactive disorder.
What I wanted to clarify, Gil, is that first of all, I love that actually you explained that it's not only high sensitive children, as many of us know and heard of, but there is also children who do not. How did you call it when there are not enough? They are
Mm,
not getting into
No.
it. What's
Yeah,
that?
sensory underreactors.
Sensory
Underreactors.
underreacted. Yes, I
Yes.
think that's super important because we don't talk about this much. From what I understand, that the high sensitivity is a sort of neurological aspect. It's biological aspect of the nervous system.
Yes.
From your knowledge and the data that we have, how many kids overall have these different types of sensory integration abnormalities, if we could call them?
Well, I mean, the data varies in terms of what percentages. There was one important study done. I think it was around like 10%, about 10% of children. I'd have to really sort of check that in the Alice Carter study where she looked at incidence, but it does vary. I think what's important to keep in mind is all of us, there's a normal range of sensory
Mm-hmm.
reactivity that's not
Mm-hmm.
pathological. I mean,
Mm-hmm.
some of us like roller coasters and some of us hate them. I don't know that that's a pathology. That may be just, within the range of sensory differences. But, then when you start to reach the point where it starts to interfere with function, and that's the
Mm-hmm.
key element, then you need to look at it carefully. And here again, I think OTs, occupational therapists, are really the most prepared, along with developmental pediatricians and pediatric neurologists, to really assess when a child's sensory reactivity and one or more sensory systems are
Mhm.
out of line.
Mhm. Mhm. Okay, sort of clarifies how it works. So, if there is sensory integration and the way it regulates and works for a child is sort of biologically set up already, what we as a parents can do and how we can help, in particular, the child to self-regulate and integrate the senses in a better way. And maybe we know more about the children who are high arousal and how to help them. But what do we do with children who lacking this connection, let's say, with the senses?
I think one of the things is for the parent to work on being a good co-regulator.
Mhm.
If you have a child who is either overreactive or underreactive, we have to enter the picture. So with the overreactors, we want to help them to modulate. We want to maybe do some things in the environment so that they're not being overly bombarded with sensory stimuli. We want to, in a sense, protect them from excessive amounts of stimuli. And
Mhm.
then we may need to be there under circumstances when they're dysregulated to help them get regulated.
Mhm.
So I think, again, this idea of being a co-regulator is important and not overstimulating children. I think today there's an awful lot of stimuli around children. I think we really want to be conscious about the doses of stimuli. I think we also want to be conscious about screen use. Too much screen use can backfire and can lead to problems later on. So the American Academy of Pediatrics and there may be European pediatricians to have some guidelines about screen time. I think that's very, very important. I think that when we're dealing with the underreactors, it's getting to know what your child's biological rhythms are like and letting to know, do we need to do something to help get this child's engine turned on in the
Mhm.
morning? Do we need to sing some songs? Do we need to do some jumping jacks? Do we need something to get that body moving? I think another important thing is play. Play is
Mhm.
so real play, old-fashioned play, and you don't need a lot of fancy things. You can do an awful lot with just blocks, water, paint, and clay. But providing children with play opportunities, because play really is a sensory experience, and children do it themselves. They don't need an imposed task, and it's a kind of arena where they can practice regulation themselves and may practice it with their peers.
Mhm.
As you know, when you see a group of kids playing, they're active, they're quiet, they're loud, they're running, they're sedentary. And so they are shifting gears. They're practicing how to shift gears. So I think
Mhm.
providing children with opportunities for play is very, very important, as well as opportunities for sort of rough and tumble activities too. Getting out into the playground, getting a lot of input through the muscles and the joints and through movement, I think is also a very, very important. And then, all the kinds of games that, again, in Cyprus, you probably have your own set of games that do the same things. Here in America, things like red light, green light, musical chairs, statues where you freeze, start
Yeah.
stop games. All of these are really ways in which we're practicing regulation and also
Mhm.
being particularly attuned to where children may have regulatory issues, may have some problems. Now, like
Mhm.
transitions are typically difficult for most young kids. So
Mhm.
we may need to put on our co-regulator hat or at least be a little more available during times
Mhm.
of transition to help.
Mhm. At the closing, I would love if you could share a little bit more information about the recent book that you co-authored. Maybe you could talk a little bit more about the book itself, where people can get it. And of course, we will put the links in the description for the video. But it would be lovely if you could share a little bit more about the book.
Thank you for providing that opportunity, Kate. Yes, as I said, my first co-author, Dr. Susan Stolen-Saylor, is in occupational therapy. We wrote the book together. It is called Linking Sensory Integration and Mental Health, Nurturing Self-Regulation in Infants and Young Children. So she really brings the whole sensory integrative piece, and I try to put it into a mental health framework, including emotion regulation. Now, from the mental health point of view, emotion regulation is where, as psychologists, we're focusing a lot.
Uh-huh.
How do we get ourselves calm? How do we not get overly explosive, for example? How do we not get so shut down so that we can be a participant? This is really emotion regulation. But I think one of the things we're learning more is that emotion regulation early on has its roots in sensory regulation.
Hmm.
And that a lot of what is emotion regulation starts with messages we're getting from the inside of our body. Here's where the physiological arousal that is a part of what becomes emotion arousal may start in our stomach, may start in our respiration. And of course, it's in our common parlance, at least in American English. I have butterflies in my stomach.
It's
right?
interesting.
I'm white as a ghost. I'm red with rage. So
Uh-huh.
I think even when we talk about emotions, we always have a bodily piece. So as a mental
Mhm.
health profession, helping children to learn to regulate their emotions, but recognizing that it has roots in sensory and bodily regulation. So we talk about those kinds of connections between the sensory piece and the mental health piece. It is a book also for parents. It is somewhat technical, but we try to translate that information so it is friendly and usable. And we also
Mhm.
offer some chapters on practical things that can be done in the home and the classroom to
Mm.
promote a greater development of self-regulatory skills.
Could you maybe provide a couple of examples again on the practical side for the parents on how to help this emotional regulation piece? Of course, I know this is age related, but maybe some of the practical, especially in the transition moments when the emotions are very high and you need to, okay, calm down and pick up the toys, for example. So, what would be the helpful tips for parents on?
Well, one might be that when the child is in a state of high arousal, one of the things I wouldn't do that we're all inclined to do, me too, is that use your words. But when the child, of course, we want them to use their words, but remember when they're in a state of high arousal, they can't access language
Mhm.
because that's too high up in the frontal lobes. We can't access it. So one of the things might be just to just get close to the child, just be
Mhm.
present, just see if our presence. Maybe we just go shh. Oh,
Mhm.
tough time, tough time. Just try to get the level of arousal down. Then, when we
Mhm.
get the level of arousal, then maybe we can start to use words or start to do something else. So, presence is a very
Mhm.
powerful thing to remember. I think another thing to for parents to think about again is that we may again need to use our own words to help the child. We may have to, cool them down. Hey, you're overexcited right now. Just let's get quiet. Let's just be still. Let's be still together. Using our presence, using our words, being attuned to the emotion, what the emotional tone of the child
Mhm.
is, and
Mhm.
helping to mirror that for the child so the child has a greater awareness of it. Sometimes it may mean providing some structure for the child.
Mhm.
First, we're going to do this, then we're going to do this.
Mhm.
Sometimes it means limiting choices for the child. You may choose between this and this
Mhm.
so that we narrow the field. So these are some kinds of practical ways in which, again, we're serving as a co-regulator here in the more of the emotional.
And I think, thank you very much for these insights and practical ideas. And I think what is important to emphasize that most of them need some time. It's not that, you're in the middle of the birthday party in some center for kids and you want to grab your child and that he or she immediately will jump into the car and you go home. That's not going to happen. So I think that for us as parents, having realistic expectations that this system needs cool down period so the child is able to follow you, to become again attached and to follow you. So that needs just pure time.
Absolutely. That is such beautiful advice. Yeah, no one does it in a snap, right? And we have to, that's right. So we have to give children enough time to change gears, to make a
Mhm.
transition. And that
Mm.
we should prepare them. We should prepare them in advance and start, as you say, start the cool down process. Very
Mhm.
important. And the second thing is, we both know this. If you've got a child who's having a temper tantrum, I don't know about you, I'll speak for myself. It agitates me, and so it triggers me. Now I got to keep myself down. So
Yeah.
we have to be conscious about keeping ourselves regulated
Mhm.
in the face of the child's dysregulation because it's contagious. If the
Yeah.
child's dysregulated, then I get hyper dysregulated and I get agitated. Now we've started a cycle. And so giving time, it's a process, and keeping ourselves as regulated as we can in a tough situation.
Thank you, Gilbert. I think that's all the questions that I have. And my 6-year-old came here as well. Come here and say hello. Hello.
Hello. Hi. I'm pleased to meet you.
he needs some self-regulation. He need a co-regulator. Let's say
I'm
like
sure
that.
you're an excellent one because you're so easy to talk to. I mean that honestly. You made this so easy.
It was a pure joy. Thank you so much for your insights and
You're welcome.
for, I felt that the level of expertise and energy and enthusiasm that you have for this topic, that's great. And I also would love you to, if you have any additional links or any additional information you want to share, just let me know, okay? Because I
Okay.
have the slides that I will put in the video that you shared with me already. I have the link to the book as well, but
Okay.
maybe if something will come up to your mind and
Yes,
you will
if something
find it.
does. I mean, there's a lot out there. So let me see if I can put some things together. Or I can also ask Susan, my co-author, if there's any.
Yeah. Yeah, and that's also what I wanted to, mention to you. If at any moment in time you will feel that she would be open to have a
Oh, I'm
conversation,
sure
I would
she
love
would. So
to.
let me
We can,
pass this on if I will. I'd be happy to.
yeah,
I'm sure she
yeah,
would. And you get it
yeah.
from the OT perspective. So it would be really great.
That would be incredibly useful, I think. Yeah, that's
Thank
great.
you,
Thank
Kate.
you,
A
Gilbert. Thank you
pleasure
so
indeed. Thank
much.
you for
Yeah,
having
have a
me.
lovely rest
Bye-bye.
of the day.
Bye-bye.
Yeah.